I can hear, by the way, if you were wanting some feedback.
We did.
Good morning, Diane. Can you hear us?
I can totally. I
Okay.
am at my goddaughter's wedding, so there's a lot going on here right now. But yeah, so anyway, if I need to, I may mute the video, but I'm here.
No worries. We just appreciate you signing in. Okay, good morning, everybody. I know Dr. McBride is on his way here, but I do believe that we have a quorum, but let's go ahead and do a roll call.
Okay, Dr. Garza.
Here.
Dr. McBride. Dr. Cunningham. Dr.
Here.
Cindy Bozeman.
Here.
Hold on a second. So I heard Dr. Cunningham, Dr. McGuire.
Yes, here.
Okay.
Okay, Dr. Meyer. Okay, Cindy Bozeman here.
Bosman here.
Bosman, I'm sorry, Bosman, and then Bishop Hankerson.
Okay, well, we do have a quorum. When Tim gets here, we'll have a super quorum, so we can do whatever we want. All right, okay, so the first order of business, though, is to approve minutes. If you remember from our previous meetings, we had not circulated these, and so we're going to be approving a raft of meeting minutes here with at this meeting, including the minutes from January 24th, April 18th, and then from our last meeting, which was held on July 11th. And for that, I will need a motion to approve.
So moved.
So move. Cinia? Can I get a second?
Second.
Thank you, Dr. Cunningham. Okay, all in favor, aye? Aye.
Aye.
I, for the one meeting I attended, I didn't attend two of them.
Okay,
I was here in July.
thank you, Diane. Okay, any opposed? Okay, motion carries. All right. Okay, so we will have a rather abbreviated meeting today, mostly because Aaron's not here. And so him being the master of data, we're going to forego some of the data. But I did want to make a couple of comments first off. So welcoming our interim director, Janelle Coleman. I believe this is your first meeting as interim director.
Yes.
You were deputy director last time we met. And so thank you. And I know we've spoken
Couple times.
a couple of times. So it's great to have you here as the interim director. Obviously, everybody, I think, recognizes that Director Bess has left the county to pursue other opportunities. So there's obviously some changes going on within the organization. And then the last comment I'll make is if you all have read the news as well, the Deputy Director, Nate, has left to go to the city jail. So great promotion for him. We all wish him well. And I think that's a tremendous opportunity for the city jail to get such an experienced operator. So I'm very excited for that opportunity for Nate. Okay, so with those, and we'll get to this later on in the conversation as well. So not truncating it, but just want to move on with the agenda. So next on the agenda is our census and supervision of the pretrial services and our population to date. And I believe that we pulled together some broad statistics on this. Again, missing Aaron, but he is off on paternity leave, and so we wish him well also, and congratulations to him. I'm having a hard time seeing that, but there's Dr. McBride.
Hi. Sorry to be late.
Being president. Welcome. So I'm just going to walk up here so I can see the numbers a little bit.
Those are our pretrial release numbers.
Okay.
Which have gone up, as you can see. We've done a really good job over the last. Like I said, I can't see the numbers.
Yeah, very good. So it says residents released on pretrial release. We have 81 September of 25. Of course, the month hasn't completed yet, so that's probably why that number is down. But if I remember correctly in our conversations, we're at some of the highest numbers that we've ever had.
Yes.
Except for that April of this year, but consistently remaining high, which is good, because that means people aren't spending time incarcerated, but they're back at their homes and being able to contribute. Thank you. Oh, thanks, appreciate it. Okay. Thank you. Always dangerous when you let the doctor drive your computer. Just saying. Okay, so this is the average daily population for September 25. You know, a few tricks. So it looks like we were at 1,256, which has come down slightly. It looks like if you follow the graph from our high about a year ago of 1,321. So we've steadily declined also from earlier this year. So that's a good thing, although it's still
very high.
Yeah.
We haven't declined that much. We were just in the 13. We dropped to I can't see that to the 1280s,
okay.
but just a week or two ago, we were around, 1306. Because this is for the,
Right.
1306, 1298. So we've been working closely
Oh, I gotcha. Okay.
with I had a meeting with the Public Defender's Office and our PRT review team to try to get some of those numbers down, because that's still very high for right now.
I see. So these are daily counts. All right.
Those are average daily
thinking-
populations.
I was thinking of a monthly, so my apologies. Yes, so I'll take back my comment. We were at 1333, it looks like, on, if I'm getting this date correctly, on September 2nd. Is where it looks like we're at 1333. So yes, significant numbers in the jail, which means in total that we have a significant population as well. So high number of pretrial release, high number that are physically in the jail. So the census is fairly high.
And we have actually 589 people on pretrial release, which is a really good number.
Mhm.
But we also have a really high jail population as well, but it's a really good number.
If I recall right, 1,300 is still above capacity.
Yes.
What's that?
I can look at the dashboard.
Okay, yeah, that'd be great. So, any of the board members have questions about any of that data? We're gonna go ahead and pull up the dashboard here. I don't have any particular data that I wanted to review, but with Aaron not being here, we thought it would be a good idea to just pull it up and see if there's any questions about any of the data that we normally look at. So we just looked at our population review, if I remember correctly. So let's go to pretrial release. And we're so fortunate to have Aaron on our team.
Yes.
Okay, so as you can see here, the appearance rate is 77%. So, which I believe, and Jonelle, you can tell me if I'm correct, in that that's pretty consistent with national standards. Okay. And the arrest-free rate is around 93%. So these are
So that, sorry if you could scroll down again, that brown graph on the top,
around
the
Yes.
pre-trial log really shows a huge increase in 2025.
correct. You're talking about this graph over
Yeah.
here? No, absolutely. And I think that's what we were talking about earlier. We were referencing
They're
that.
sort of linking these,
Mhm.
those other numbers.
589.
So this is the GPS, this is pretrial release, and so we're at 589, and as you can see, that is the most that we've had on pretrial release, at least from when we started
Yeah.
looking at this data in 2021.
I think it's just important to keep pointing that out because it's creating, just creates a lot of demands on the jail.
Okay,
And it's outside forces, really, it's not
right,
anything else.
right. We don't load the buses, we only drive them.
Right.
Okay. Any other questions from board members on the pretrial release dashboard? Okay. now I've navigated away from the page. But I can find it. I know.
Can't control them.
Okay, so population review. Okay. And these are just recommendations. My PSA score, we've spoken about this in previous meetings. Number of individuals reviewed. Okay. Not gonna spend a ton of time on that one.
I always look for a change.
Right. So this is clearly the one that we are concerned about is the increase in population starting in 2023 is quite dramatically up to the present time.
You know, if I recall, Alex, you and I have been here, sorry, Alex, call you Alex.
No, you're
I've been on the board as long as you have, and that number is approaching, if not higher than anything we ever saw when we first started.
I believe you're correct.
When we first got on the board, it was.
I think it was less than 1,000, wasn't it?
Oh, well, yeah, it'd be interesting to go back and look, but it was.
And then just looking at this charge status category, so the bulk of those are here in pretrial. Probation violation. Okay. So that makes sense. And then the offense category, the bulk of them are pretrial felony A's. I don't see any, well, felony E's seem to be
Yeah,
making
A
up a
and B
bigger
would
piece
be
of
in
population.
pretrial.
Yeah.
CD and E felonies are pre-trial.
But it looks like, at least starting from 2023, there's an increase in all of the categories, but I mean, just to the naked eye, it looks like the D's and E's are making up the bulk of the population.
And that's why there should be more, and that's why there should be even more of them on pretrial.
Right.
And that's the kinds of conversations that we're having. We have a lot of people that are, the majority of our jail are D and E felonies,
Yeah.
which means that many of them are able to be on pretrial. It's just working with, the prosecuting attorney's office to,
Of course.
yeah.
And if I recall, the DNAs are often, they seem to be predominantly gun violations now. Is that right? No?
Not the D and E. Although the ones that they won't let out usually have some sort of gun related to them, whether they used it, they could have brandished a weapon, they could have had a weapon. They just have right now, honestly, they have somewhat of a policy that if a gun is involved in any way, regardless of how it's used, that they're probably not going to allow them to be on pretrial.
Thank you.
Right. Then I would encourage board members, if they're interested in diving a little bit more deeply into the dashboard, please go to the public website. And continue from there. Just really briefly, going to go to the administrative dashboard, and then we can switch over to our friends in medical. Okay. Again, apologize, I should have looked at these beforehand, but Tim, you always jump on the ratio, so there you can see it's fairly high. Corrections officers to population ratio.
Driven by the numerator, probably, mostly.
It does look like the ER runs and the hospital posts have gone down, so that's good. So credit to our medical team. And the jail visits remain pretty consistent. Okay. The open positions here seems to be coming down. Any comments on that, Jenna?
Only that I'm trying to fill them all.
Yeah.
I have a lot of, especially the higher leadership positions. I have a superintendent position that I have interviews for next week. We have a new major who is actually the acting deputy director right now. We have a unit manager, we're just waiting to get the numbers right on their salary. We have to go to county council about that. So my goal is to definitely fill the gaps in those leadership positions, which will create some right below that. So probably for the next 2 months, I will be spending a tremendous amount of time on trying to fill positions. Of course, the CO position, we talked to council about, I've talked to across the street about the importance of being competitive in pay. We have a very small pool of people, but we have a lot of jails around here that compete. We have St. Charles County, St. Louis City, us, Warren County that is close, Troy is close, Wentzville is close, and we all need officers. So we have to be competitive in the salary in order to get those officers. So that is something that is ongoing. Also, I am very much, and we've had this conversation, if in probation in that period, you're showing that you're not going to be a good officer because you have, 9 days of unscheduled time off and you're still on probation, I'm not trying to keep those types of staff because you're not going to be here anyway. If you're not going to be here during probation, you're definitely not going to be here after you're off probation. So there's still an issue with turnover a bit, and we'll continue to work on that, but we're still going to be pretty solid on not keeping staff that's not going to be here anyway.
Do we know how competitive St. Louis County is compared to the region?
We're
As
the
far as
lowest.
salary, we're the lowest.
We're the lowest between us, the city, and St. Charles County, for sure, we're the lowest.
In that order.
I think it's St. Charles County, St. Louis City, and then us.
Doesn't make a lot of sense to me, but
Yeah.
we're the richest county.
Yeah,
And I know that we did just get some, we did get some bump recently, but it still didn't put us to a point where we're competitive with them, we're still the lowest. So also, the Wall Group that helped recruit, they're about to start recruiting for the city too, so that's gonna be no good for us,
they're a recruiting firm for corrections officer positions or?
Yes,
Okay.
right now.
Okay.
But they're going to be, we don't sign any type of non-competitive, like you can't go work for other people, so they're
Right.
gonna work for the city. I don't think it fell through I think they're still gonna work with the city and, now they're gonna be, it's kind of, to me, it seems somewhat of a conflict,
Yeah, a
but
little bit. Yeah,
Right.
okay. Okay, all right. Well, thank you for that insight. I think that is definitely something we need to advocate for, is to help you do your job with being able to fully staff the Justice Center, and people vote with their feet. They're especially, if the economy contracts, you're going for those higher wages. Okay. Any other questions from board members about the administrative dashboard?
I'm sorry to be catching up a bit,
You're fine.
but can I go back to the pretrial dashboard again?
Sure.
And I just have a quick question about it.
Pre-trial release dashboard?
Yeah. If you scroll down to the bottom, what happened in April? Those peaks are all in April. So it seemed like most of the problem we're having here is, like, all those graphs look semi-normal. Take April out of it, they'd be fairly flat.
I don't know of anything, March, April. I don't know of anything specific that happened in April.
I don't-
Honestly, I don't, I
I
can't think of
don't recall
anything
either.
specific in April that would have made that dip. I can look into it, but I really don't have an answer for you right now. I
Just
don't
a
know.
little bit of a puzzle, because it looks like that's a big part of our issue.
What is that?
Well, it just seems like a lot of the numbers are being driven by that April peak.
You mean
Maybe
the
some of those people may still be around.
Yeah, it can definitely affect your averages.
Anyways, I'm curious.
I just don't know. I want to know myself now.
Yeah.
Look into it. I want to know.
People were into spring, they got real rambunctious, I guess.
But we definitely saw fluctuations in the data when COVID was around.
Oh, yeah.
Population dropped considerably. But, no, that's a good point.
Okay.
Tim, thanks for bringing that up.
I can actually, well, I can't do a drop down on that month.
Okay. Any other questions about any of the data on the dashboard? So I think we've identified one issue with the staffing.
Mhm.
That we need to keep our eye on and be advocating for. Okay, great. All right, so moving on to number 4, corrections medicine summary. Dr. Oldig,
Sure.
Dr. Cunningham.
Let me start. And as it was stated, Erin is still out on parental leave, so our medical data was not uploaded. So therefore, we don't have any slides today. But I will be using actual encounter numbers to present to you today. I will cover medical, and then Dr. Oldig can give you a quick overview of mental health numbers. So at the last meeting in July, I presented on Q2 data. So I will cover July and August, and then next time when we meet, we'll be able to provide you detailed data. So I'm using book count numbers, which is the total number of bookings for the month of July and August, and that was data that was provided by Justice Services. For July, it was 1,091, for August, 1,194. We talked about transportation numbers, those were down, so those include ER runs and hospital runs. The number was 43 for each July and August. The medical team is doing a great job of taking care of what needs to be taken care inside this building. So we are sending out less residents, patients. Our medical clinic encounters were 388 for the month of July and 438 for August. The infirmary, 50 for July and 41 for August. Our total chronic disease management numbers for July were 123 and for August 100. There were no sentinel events, and there was no M&M. There were no M&M reviews. And one exciting news to share: we actually have a tentative go live date for the Epic implementation for next year, and that is July the 21st of 2026.
Oh, wow.
So it is a tentative. We are on track right now with our program process management. So it's an exciting news, and we look forward to that date next year. So that's all I have. If there are any questions, I'm happy to answer. And then Dr. Oldig will provide a quick overview on mental health.
Any questions from board members? The numbers good?
Maybe after the mental health one.
Sure,
Go
sure.
ahead.
Sure, so, no, thanks, Ava. So for our mental health numbers, again, we're all missing Erin. For our psych clinic numbers for July, there was 333 patients, August 350. Those are fairly steady, down a little bit, in part because our full-time psych provider was out on vacation for 2.5 weeks. And a lot of those patients were seen by the medical staff, including myself. So patients were still getting seen, it just wasn't coded as a psych visit. Psych infirmary for July was 47 patients, for August is 90. Again, that's because the psych provider was out and the medical provider was actually making rounds on those patients. So needs being addressed, just it was coded a different way because a different human was seeing patient. Other news and notes that way, we are working with the Washington Brown School of Social Work to expand our services for mental health in the building. It's really exciting. We are looking to pilot a program to have social work students in the building to facilitate group therapy, individual therapy, and a structured curriculum, particularly on the therapeutic pod and those to a certain extent in the choices program. So that's gonna really be a huge boon and a huge service that's necessary for the patients in the building. Right now, our medical and psychiatry, like our provider coverage is robust and I feel pretty appropriate. It's the additional services that are necessary that we just simply don't have. So we're in the works of being able to build up counseling therapy groups that right now, for most practical purposes, outside choices, we just don't have in the building. So as far as mental health goes, that's something that we're really looking forward to.
Great.
Other news and notes, in terms of patient safety, I know there's been questions about why are safety events reported or not. We're switching to a new system as of this month. So instead of sending an email, there's gonna be an icon on all of the nurses, medical staff's desktop to click on, fill out a form, more similar to what would be in a traditional hospital system. And I'm hoping to have a little more engagement that way from the staff. I think it was, staff was in the middle of 100 things, didn't feel like going in, logging to their email, filling it out. And there was also perhaps some, hey, I fill this out and nothing ever happens. And we're really trying to change that. So our safety numbers won't necessarily mean that care is getting worse. It just means that people are coming
Right.
forward with questions or concerns.
Right.
So if there are gonna be changes in the numbers, that's gonna be part of it. And I think it's actually better for everybody.
There's always that dynamic,
Right.
in healthcare.
Yeah.
So people equate with reporting of, safety events as a bad thing, but it's actually a good thing
Yeah.
because that means people are comfortable enough to,
Right.
to report
Right.
issues. You worry when you have a low number, because then you worry about what am I missing or are people not.
Right.
So, yeah. Great. Tim, do you have a question?
Yeah, well, a comment first. Good work as usual, because the numbers, you report a lot of good things. So as usual, I think you all do a good job. Number two, the Brown School thing, is that an internship or practicum?
It'd be a practicum,
Yeah.
a practicum under the auspice of the school of social work.
That's what I thought,
Yeah.
yeah. So, just one person right now, or?
It would be, the tentative plan is to have, once we hire a mental health manager, because that position's about to be posted at long last, to have that person be credentialed as a full-time LCSW,
Okay.
MSW, to then to have the appropriate mentorship for LCSW students during their practicum. And so the thought was to have 2 students at a time, kind of tag team it.
Oh, yeah, okay, good.
It's a jail, getting the right students for the space. 'Cause jail is hard, it's not for everybody.
No, it's not.
No.
I'm glad this happened. I talked to Director Burris about this a while back. He was
Yeah.
really wanting this to happen, so.
Well, I can't let this pass. I would be remiss if I didn't say that the idea of the therapeutic pod comes from Keto Vets.
Oh,
That's where the idea of
Thank
this
you.
comes from, and I, as the deputy director, I was working on it with them as well, because I started mental health at St. Charles County. So the jail is very much involved in there, and Keto was very much at the genesis of this idea to have a therapeutic environment here and a housing unit to mix co-occurring mental health issues with our current Choices Housing Unit, which we are also in the works of updating in the immediate future.
Well, that makes a lot of sense because it's happening now, so you should get the credit for it, and you all should. So that's great news. So I had a question about the mental health disorders and the substance use disorders. As I'm looking at the graph, I think we talked about it last time, I just kind of want to keep it in my frontal lobe.
Sure.
So it's kind of, you don't have to pull up the graph if you don't want to, but it was puzzling to me, but there's been a pretty big increase in opioid disorder, percent of provider visits for opioid gone from like 6 to 17%. And then, but there's been a pretty big drop in mental health disorders at the same time. And so it's, the way I interpret it is we still have issues around behavioral health, broadly defined, but it's more opioid oriented than non-opioid and mental health. Maybe I shouldn't put those in the same bucket, probably not. But can you just comment on, the stress that's putting on you in the jail in terms of opioid disorder?
Well, as I had mentioned briefly at our last meeting, some of the numbers might be, and some of the provider visits are because our MAP program we had to tap the brakes on the MAP program because we didn't have funding. The county council was able to provide the opioid settlement funds to provide, funding for medication, so we could reach more patients. We were at the point we physically couldn't reach everybody, and we had to, I hate to say, cap the number on the program, because we physically couldn't do that daily med pass. And that really, it hurts me as a provider. I don't like rationing care. It's the last thing I want to do. But we weren't seeing the patients because like program was full. Now that we have more patients in the program, yeah, we have to see once a month. So that's part of the reason. And also the incidence, yeah, it's still there. I mean, the number of deaths have really gone down. Morbidity, mortality has really improved in the St. Louis region. However,
Across the board,
it's still, yes.
Across the board.
Across the
not in the justice center.
Yeah,
Just wanna make sure
across
I
the
point
board.
that out.
Thank you. Thank you, yes, thank you, yes, thank you. But in the region, but the number of people who suffer from opioid use disorder, it's still extremely prevalent.
Yeah.
Still
And
extremely
maybe
prevalent.
probably rising in the St. Louis area and the nation. Yeah. So I just sort of pointed out that you're facing that. It's interesting to note, you know, the points you importantly make about some of the data may be reflecting services provided
Right,
versus not. And so we want to make sure we don't attribute it to something else, kind of like the autism thing. It was probably always there, but we just didn't identify it.
Right,
So
right.
until we started diagnosing it.
Right.
So.
Yeah.
Sorry.
No, you're fine. I mean, it's a sad reality that justice services and jails are the largest provider of mental health services in the country. And so we have a higher segment of the population with mental health disorders that are incarcerated than the general public. And so it's an unfortunate reality that we have to deal with. And on top of that, the substance use disorder issues as well, which have become increasingly difficult to manage with the introduction of fentanyl,
Right.
and now with various other drugs that are on the streets as well. So it's an evolving and constant battle to take care of these patients.
It's really sad that our jails are our mental health system.
Yeah, no, for sure.
Is there any correlation or difference with respect to prescriptive opioids versus I guess it turns into a street opioid if it's an addiction, and then mental illness? Because I thought I heard kind of a difference in the two.
Yeah.
Right.
I was
Did understand
conflating
that
those two,
correctly?
and I'm not a doctor, so let's.
Wait a minute, can you say it again? Is there? Yeah, I'm looking at the prescriptive opioids when people get addicted to prescriptive drugs, and then the street drugs, and eventually that turns into that if they become addicted. But then when we talk about mental health issues, is there a correlation or bridge to the mental health challenges and the opioid addictions, and the difference in prescriptive versus abuse?
So that's two different.
It's
Yeah, it is.
So-
It's two questions.
Yeah,
So
so, okay,
lack
so-
of knowledge here, I'm
Jump-
asking all
yeah,
these
absolutely.
questions.
Jump in if you want.
Yeah.
So, historically,
Probably created
so
that confusion.
early 2000s, it was prescriptions. People were doctor shopping, getting the pill bottles, going from here, going to there, going in grandma's medicine cabinet. Then it evolved to the physicians stopped prescribing as much because we realized what was going on. We realized that the drug companies were selling a bill of goods. The half-life really wasn't like 12 to 18 hours. It's more like 6 to 8. People needed more because that's how neurophysiology works. It's neurobiology. It evolved from pills to heroin, and then heroin went away, and now it's fentanyl. Fentanyl is incredibly more potent, and there are a lot more adulterants in the drug supply. So meaning veterinary anesthetic agents. So xylazine is one, metomidine is another one, where people can suffer from like really bad skin wounds with xylazine. It's not just from injection. I mean, it's like their skin is like rotting off it. It's really awful. So there are other comorbidities that go with that. So that's the drug portion.
Okay.
As far as the mental health piece that goes with it, to some degree, it's chicken or the egg. I mean, some of the folks suffer from serious mental illness and they're self-medicated. Okay, and that's part of it. And there are other people who develop depression, anxiety, PTSD from the circumstances that surrounded their drug use, the acquisition, particularly in our female clientele. I mean, do you exchange like sex or money for drugs? Like where have you been for this? And yeah, so then that can also then lead to a subsequent mental health condition.
And keep in mind that substance use is listed now
Yeah, it
as a
is, yeah.
disorder in and of itself.
Yeah.
Just by itself, it's
Yeah.
listed as.
I mean, it's a chronic disease, so when I separate chronic disease, like it is a chronic disease, I mean, it rewires the brain.
Absolutely.
So
I hope that clarifies some of it for you.
Yes, thank you.
Yeah.
Very
Right, so
helpful.
there's a broad sort of mental health, behavioral health, whichever term you want to use. And then within that is a subset of people that are also substance use disorder. So you can have like schizophrenia or bipolar disease and not be an opioid or other addict,
Yes.
or you could. So it's
I've lost audio, just FYI. I don't know if anybody else is having that problem.
Yeah,
I
we're
did.
taking a
I
look at
did
it.
too.
Yeah. Okay. Hello, everybody. I apologize for the technical issues. But we are back on now. So, and I believe people can hear us. I just want to double check our comms. Yeah.
Yeah, I can hear you, Dr. Garza.
Okay, great. Thank you. Okay. I think the only thing you missed was Interim Director Coleman's comments about behavioral health, mental health, and substance use disorder. how those all play together. So we haven't moved on to any other topics yet.
Okay.
Any other questions for board members for our corrections medicine?
I do want to just have one comment. First, thank you, Dr. Odag and Ava, for highlighting the great work that we're doing at Corrections Medicine. The one, just so you all would know, one advocacy piece, the health department, we are in budget season with the county right now, and the corrections medicine budget is about 20% of the entire budget for the health department. So it's a big discussion coming up about how to maintain the staffing and the funding. Of course, we spend a lot in professional services. We have vacancies. So just wanted to let this group know that that's a serious topic, and one that, I'll be discussing with the county council during my budget hearing. There have been some meetings, one-on-one meetings, in which we've had some discussions about the corrections medicine budget and what we can do to preserve it. One proposal, I am proposing the idea of using opioid settlement funding to fully support the opioid and mental health program in its entirety, including staff, salary, and fringe. That'd be a one workaround right now, but just want to let everyone know, like, that's a really, really big topic, the budget and what we're spending at corrections medicine. So wanted to put that out there. May need some advocacy and some support, or even, there's some additional thoughts on what we can do as corrections medicine to make sure we can maintain staffing, but then also try to reduce professional services contracts while still providing the care to a growing population.
Yes, Dr. McBride.
Can I make a couple of comments? Thanks for making those comments, Dr. Cunningham. I didn't realize you were, you had that presentation to the council. A couple of things I might throw out as possibilities. When
Okay.
you see reports about, relatively good numbers, except for the opioid issues, which I'll get to in a minute, it might be worth pointing out that having a relatively good set of numbers means we need to maintain what we're doing.
Right,
Because
correct.
You do not want to actually cut the funding,
I agree.
blow up, because that's like, so actually people might look at those numbers and say, oh, we don't have a problem, we can take money there. But that may actually be an indicator that we're doing the right thing.
Right.
But two, I think I would point to the opioid issue and remind people that it's not an issue, it's a systems region. Number three, I didn't ask the question, but it might be worth pointing out, and it fits in the first bucket. I think, we've had, as you know, outbreaks of various infectious diseases in the community. COVID, I had a really bad, whatever the virus was, it's not COVID, but I'm still recovering from it. So just you will, when you get it, this cold goes on for about 14 days. So I think I'm still okay. Everybody's moving away from me now, so, and, of course, measles and everything else is like, so I just sort of point that out, that it's worth pointing out to the council probably that there are always challenges, even if we're not in
Yeah.
the pandemic. And, as I always said, we did better than, almost anybody that I know in the COVID.
Yeah.
So in our jail. So it's worth kind of pointing out that success means don't rock the boat.
Right. No, I agree. Completely agree.
I have to worry about Chagas disease.
Yeah, right.
Yeah.
It used to be an exotic tropical disease. That carry it.
Kissing
Right
bug.
To Missouri.
Yeah.
Heard about that the other day. I remember learning about that pathology about one of these states.
My wife's concerned.
I've been to Fort Mill.
Oh, really?
Yeah, I read about it a few years ago about the armadillos in Missouri. In fact, if you drive down 61 hit on the road a time or two, because I drive down 61, yeah, they've been here for a minute. Very invasive,
Yeah,
Okay, all right. Any other questions for our corrections medicine? Sorry, we digressed there.
Oh, yeah.
Okay, I'm going to turn this over to Acting Director Coleman for her updates, comments, and issues.
I think that I'm a pretty direct person, so I like to face the elephant in the room first. We did not pass the ACA audit. We are still accredited with the ACA through January, the end of January. Many of the issues, there were two primary issues. We have not received the report back yet, but I'm aware of two of the primary issues, one of which was the kitchen. We outsourced our kitchen to Trinity. We currently have Trinity in the building. They're higher ups working on the issues that were presented. We continue to work with Trinity for them to come into compliance. That's part of our contract, that they would be in compliance with ACA. On the first day, in the first part of the tour, with the first place we went to the kitchen, we did not pass. And right there we knew. There are mandatory things that must be passed. And that was one of them. So if you don't pass one mandatory, you didn't pass. So we knew at that moment that we weren't going to pass. We have involved our legal to some degree, letting them know that we believe that there is some violation of the contract, and we're working on it right now. The other major issue that was discussed were our showers. We've known for a time that we have had issues with our showers. We have presented, and just as recently as yesterday, we've had a meeting with facilities about the showers and working on some of the issues are going to bond. The other issues that we may be asking for emergency funds to address, but we were aware of that issue as well. We are working closely with the ACA to come back into compliance. I think we're going to have a mock audit as soon as, I want to say January or February around that time. And we'll have the opportunity to come in compliance again in March. An additional piece to this that you may not know. We do not have to be accredited through the ACA. We are the only jail in the state of Missouri that is accredited through ACA. It is a decision that we've made that we want to hold ourselves to that standard, and we intend to get back to that standard, but we don't lose anything by not being accredited through ACA. We gain things because it says that we want to adhere to this standard. So nothing bad happens. If we were to say we don't want to be accredited by ACA anymore, we just wouldn't be. It wouldn't stop us from doing anything. As I stated, we're the only jail that is. But we want to maintain that standard, and we are working hard to get back into compliance, even as we speak. So that was one big thing. Dr. Oldek did discuss the therapeutic housing unit, which is a source of pride for us as well. When I came here as a major, as I said, I came from working extensively with our medical department at St. Charles County on mental health issues. I worked with suicide individuals that had suicidal ideation. We grew into having a behavioral health unit, so this has kind of been my jam for a minute. And I did realize as well, talking to him, that we had very little, based on the size of the jail that we have, knowing that up to 80% have adverse childhood experiences. We had basically no counseling, and I thought that was a big to-do as well. So I strongly supported and continue to support and will support whether I'm still the interim director or go back to being deputy director. I will always be involved with the therapeutic community, and I will always support that. So that's a big source of pride for public health and for the jail, because there is not another jail in the area that has a therapeutic environment per se. Some may have more counselors and stuff, but they haven't provided the therapeutic environment that we're attempting to create here. So it's a source of pride for the jail, as well as we recognize the amount of individuals that we have with co-occurring disorders here. I think that's all I have on my list. I didn't have much more for my first meeting. I will try to have more things later. I will add one thing that just came about. As you know, we have a chaplain, and our chaplain is working with us having a pilot program of bringing additional individuals who are in, I'm sorry, I can't think of the name of the school off the top of my head for chaplains.
Eden.
Seminary.
Eden Seminary, to bring them, that's another pilot, so that they can have more chaplains in the building to be able to talk to more of our residents. And that's part of the problem right now. We have a lot of residents that have, like I said, trauma, a lot of residents that have mental health issues, and a lot of residents, just the nature of being in jail. that need people to talk to. We have a shortness of staff, so our staff is worried about doing the operational things, not so much of listening. So having this chaplain who wants to start this pilot gives us another opportunity to have individuals in the building to be able to meet their spiritual needs as well. So we're working on that as well.
Thank you. Just for my education, could you just briefly describe what a therapeutic housing unit looks like, or?
A therapeutic housing unit, ours, what we're intending, it looks like we're going to take the people, we currently have a housing unit where we have people that have mental health issues, not SMIs, not serious mental illnesses, but mental health issues, where we take them and try to give them more time out, more space, freedom to move around. There's a lot of statistics that say people that have mental health issues are more likely, A, to stay longer, B, to be bullied or victimized. Them being together kind of lowers that. We want to bring the choices in there as well. The choices are our substance abuse individuals that know about that program. We're putting them together. We want to create a therapeutic environment where even the look of the housing unit is different. We want to have more counseling sessions, more group therapy inside and out. We want to give them more freedom of movement in there. And it just looks like a more therapeutic environment that looks more like less like a jail, I'll say, as best we can. Personalized treatment plans and case management, behavioral interventions, reentry readiness plans. We're going to have some of those things in there. We want a calm, recovery-oriented environment, furnishings that support that.
Thank you. And then just really briefly about the ACA. So just to put it in context for people that work in the healthcare industry, this is sort of like the Joint Commission for corrections. Although in Joint Commission world, if you don't pass, then there's consequences down the road with Medicare and other things. That's not the case with ACA. It's not like we stop operating. And so the comments are absolutely correct. This is something that we choose to do because it's a standard that we can point to and say, hey, we've achieved this standard. So I don't want to say it's not important. It is important, but it's also not necessary. So I just want to make sure people understand that. And then the contractual relationship, the jail administration is working with that contractor.
Discussion.
Yeah, right. The comparison I'm going to make to the hospital side is we contract with a lot of services. One is for food services and one is for housekeeping, things like that. So it's that same sort of relationship, just in a different venue. Yes, Dr. Brown.
So thank you for your frank and important report. Really impressed with your interim leadership. I'll call you director. Appreciate you stepping into this role. So this report, and I read about it in the newspaper, will say raises concerns for me, and as a board member, that's our job, is to provide oversight, and to raise issues where we see them. And Dr. Garza and I have been on the board long enough that we know that when there were significant concerns before, we raised them by alerting the executive and the council about these issues, and that led to an outside audit, which I think was very productive, and led to a lot of positive suggestions, which many of them have been implemented. So actually, I think I'm fairly proud of what work the jail has done in the 10 or so years that I've been on the board. I think we're in so much better place now than we were, but I don't want to see that kind of go backwards. And I notice on your there it says ATA accredited. So even though it may not be required, it's a badge of honor.
Very much so.
Yeah, and so I think it's important to point out that that's that's where it kind of matters, probably. And I know it took a lot of work to get the level.
I was actually here the first time when we got accredited. I was an officer here when we first attempted, so I understand what it takes to be accredited and how difficult it takes to keep your accreditation. But I agree with you completely. It does matter. I believe in standards.
Yeah.
And I believe in the jail being held to the standard that we decided that we were going to hold ourselves to. So please don't let my,
Oh, no,
I'm not like, no big deal.
Yeah.
I don't feel that way. I feel the opposite of that. I'm just putting it out there for full perspective of what it does mean and what it doesn't mean.
Yeah, so I just wonder, no, I didn't, I think the fact that you brought it up so frankly is, well, that's important. It spoke volumes, the fact that you're working on the issue and, so I just sort of bring up the issue and I don't know what we want to do with it as a board or maybe the chair of the board, just to elevate these concerns because we're in this room and, I'm not sure if anybody's listening, but we could think about elevating these concerns to a higher level. The council or the executive, just to say that, we've done it before, just say we have some concerns.
You may, I feel like, I'm sure that they're both aware already. I'm positive that they're aware. And I'm just going to be honest with you, at this point, I would ask that you give us till the time for the next audit to fix it, because I don't believe that there is much to be fixed. The report is not out, so we haven't even had the opportunity to see everything in the report. Many things in the report have to do with paper. And the difficulty with auditors is that they're not all the same. You may have one auditor that wants to see a year's worth of this and some of this, and you have another auditor that doesn't want to see any of that. They want to see this. So there's not a lot of consistency in what the auditors are looking for. Even so, I'm aware and was aware before they left of what the issues are. I guess I'm not very excitable about it because I honestly believe, first of all, I know that the county executive is already assisting and attempting to assist us with the shower issues that we have. That is a major issue. And like I said, we had a meeting about that as recently as yesterday. When there's money involved and there's funds involved, it's always, where are we going to get the funds? So that is a major consideration that we talked about and prioritizing which things are the most important. The issue with the kitchen is one that is being addressed right now and it will continue to be addressed to whatever outcome that is, but we expect to be prepared. Like I said, I'm not excited because I believe that most of these things are things that we can fix relatively easily and that by the time our accreditation ends, we should be well on the path to becoming accredited. It benefits the ACA for us to be accredited as well. They want to support us. So I think with everyone wanting us to be accredited, I don't foresee it being a problem long-term. We were not surprised at this point that we did not pass. It was not something that we didn't know and that we didn't expect. Honestly, I think it has been beneficial because it has brought attention so that perhaps we can get some of the things that we have been asking.
Right.
So there's no fear about us passing it. I'm glad that it's highlighted some of the things that we believe that we need.
Yeah, and that's the spirit of my comment, actually. It's not throw stones or whatever, it's just,
Yes, sir.
it's, just to get the council or the executive to say,
And we would appreciate any assistance you can
like,
give us in that.
previous discussion in correction medicine, say, there's, you pay attention and, money may be needed or whatever it is.
Yeah.
Just, just don't let this.
No, we appreciate any assistance, yeah.
There's a comment in the chat. Oh, can I,
Oh, from Dane.
but I appreciate
Yes.
that dialogue.
Thank you, Diane. And her comment was also probably helps if there is a liability suit. I'm assuming, Dr. McGuire, you were talking about being ACA accredited.
Yes, I made that comment when we were talking about that.
Yeah.
That's very true. That's a very good point as well. When there is any type of suit, one of the first things they talk about is training or accreditation. Well, why did you do it like that? Well, we're meeting national standards by doing it this way. So you're very correct. It is helpful in any type of liability, so agreed.
Okay. Any other questions? I saw that you had body worn cameras. I didn't know.
Oh, I did have that. So, yeah, thank you. So, we had already started having body worn cameras. We're working on, by the end of this month or the beginning of next month, having every officer. We started out with the high-risk areas, intake. We started out with the 8th floor, infirmary, places like that. With our goal long-term was to have every officer in a body-worn camera. We expect to complete that, like I said, by the end of this month or the beginning of next month with on 4, 5, and 6, the other 3 floors that were lower level floors that we still believe. I am a big fan of body worn cameras. I think it addresses behavior from both residents and staff. When you know you're being recorded, it kind of helps everyone's behavior. And so we intend to have those in full use throughout the jail in pretty much immediately.
Big step forward. Okay, any other questions from board members?
I just got one question
Yes.
regarding the HCA. We're the only ones that's doing that in the region. Is there a reason why others wouldn't want to be held to those high standards as well? Do we know why the other,
It's
is
difficult.
it a cost? or-
There's a cost and it's difficult. It's both of those things.
That's concerning from a regional standpoint.
And there's a cost and it's difficult to do. I don't know how many, but you know, there's more jails that aren't than are. I can tell you that. I work with NIC and I travel, well, I did travel a lot.
Right.
There are more jails that aren't than are, because it's a high standard to maintain, honestly, and it's difficult to do. I mean, it's changed some. I remember the first time we had to measure fluid ounces in bottles throughout the jail for chemicals. That's how tight it used to be. I don't think it's that tight anymore, but when we started out, that's kind of, we had to keep that kind of track. So it's a difficult standard, and that's why I'm proud that we're able to reach it. But it's difficult to maintain, and we intend, like I said, we're not far off. It wasn't like we just blew it out of the water like, you're terrible. But the major standards, all of them must be. And so you miss one, like I said, we didn't pass from the first standard in the kitchen the first day. So from there on, we already knew, you know. So, but that's probably the biggest reason why it's a difficult standard to reach and to maintain.
So, sorry if I can follow up, having gone through accreditation myself at the academic level, it's probably totally different, but there was sort of pass, met with comments and then non-pass or whatever, and it was kind of final when they said that, but is it possible, like if you interim solve a problem, as you said, the report's not written, if you, in an interim basis, go back and say, look, here's evidence we've solved the issue that the one ding we got, that they, when they issue the report, they may change their vote and say accredited.
Well, we're not unaccredited.
Yeah,
you're
still accredited.
Yeah, we're accredited. So
Right.
like I said, I keep making that point because it is,
Yeah.
because, you know, there's things that you read that you're like, that's not true.
Yeah, well.
But,
you know,
but yeah, we're trying to make, our goal is by the end of that January 30th, there may be before the first quarter is over, we intend to be fully accredited again. That's our goal.
Yeah.
And that's why we're saying in that March area, we're gonna have a mock audit before we have the real audit. And by the time the real audit is here, we expect to be set and ready. They do their audit, we have everything, and we're done. I don't even like the idea that there's going to be any lapse in our accreditation period, but I'm saying that it's going to be very brief if there does have to be a lapse.
Great.
So like I said, they want us to be accredited as well. It's beneficial to them as well. So all parties involved, I think, recognize the importance of us being accredited and want us to be accredited. And so if we're all on the same page, I see no reason why we may fail. We're gonna get there, and I'm not concerned about it. I really think it'll be relatively, not simple, but I think we're not so far outside that it won't be hard for us to get back into.
Great.
Thank you.
Appreciate the can-do attitude.
Any other questions from the board? Okay. Do we have any public comments?
There's no public comment.
All right, so we are at the point in our agenda where we're going to set the next board meeting. A couple of things that I wanted to briefly discuss here is one, the dates, and then potential topics for our next meeting. So did we have one on the calendars? Ellie, I'm looking at you for the fourth quarter.
No, we could assess it, it was,
Yeah, and it typically is because of the holidays.
exactly, and then that was briefly discussed at the last one. So,
So we want to do it quarterly and sort of the third week. Which of course would be in November, we can't do.
Right, so that leaves us, you know, really, we can do it at any time in the fourth quarter, but typically that means, you know, the October, November, December timeframe. Seeing if there's a lot of holidays and things in.
December, any of those December dates work for me.
I'm just looking at my calendar and it looks like the 12th is a good day for me. Look, staying on Friday mornings. Cindy, I know you travel on some Fridays.
But the 12th works.
The 12th works. Dr. McGuire, how does December 12th look for you? Are you gonna be in the middle of finals or something?
Yeah, I was trying to look at that right now. I think I will be okay. I'm looking at I'm trying to look at the syllabus for my class actually. So hold on a second.
Yeah.
I'm okay on the 12th.
Okay, great. Can we send out an invite for the 12th?
Friday, December 12th?
Yes, same time.
Okay.
Okay. All right, and then just question for the board, any topics we would want to discuss at our next meeting, in addition to those sort of regular scheduled things that we do? Is there anything in particular that we would want to discuss with directors?
I think an update on the status of the ACA, just the progress, you know, you're working towards that, and it's not due until, you know, 2026, but just the progress, any issues that have occurred as you go through it. I'd like to get an update.
I agree with that, and what's the cadence for the budget request to the board, and what is that? I mean, the council, how does that work? I heard discussion.
October, we have a date in October, so how they're doing it this year, as I recall, is that we have 15 minutes to speak, and then we have a council member that speaks on our behalf.
Yeah.
And they do the majority of the speaking for, afterwards. So we have meetings and conversations with them to share what, you know, what's important to us. We get our 15 minutes, and then our council member, which I was extremely on that.
So by December, it'll get resolved, it'll be sent.
I believe so.
Yeah, and I'll make you can include it in your report, I gather, but you know, just what happened. We don't read it in the paper, but it could be wrong.
So, yeah, so it's an annual budget, it's calendar year budget.
Right.
Yes.
So it doesn't track the federal budget. And so do you know when you're guessing it's a hearing or appropriation?
I'm gonna tell you, I think it's October 12th, but I'm not 100% sure, and I'm sorry, I don't know off the top of my head. I can send my office, and I have it on there if you want to know. It's like the 12th or the 18th or something.
Sounds good.
And I also know that it's not in our purview to be involved in this, but it would be good to hear updates on their vision in the leadership. At that point, I'm sure we will hopefully know about that, but we get advice on that in the past, so it would be good to hear about that and be apprised of it.
When you say transition,
The leadership transition.
Yeah. So I think, you know, it's in many ways, Director Coleman's in a little bit of a tight spot here because she's been in this seat for like a week and a half. So
Exactly.
So, but I do think it would be beneficial for the board just for you to, you know, talk about, hey, this is what I've seen or learned. And you even been in I know you're here previously, but here recently, you were still relatively new as well, since we introduced you at the last board meeting.
Mhm.
But it would be nice just to get your thoughts on, hey, this is what I've seen, this is what I think, you know, we could do some improvement on, or what our challenges are. Whatever your thoughts are.
Okay. Yeah, we just had a meeting. I just had a meeting with all the leadership. What was that?
Tuesday.
Well, this is actually topics for next meeting, so you probably want to go over them since they look up as well.
Yeah. So we can say that for.
Okay.
All right. Anything else we need to bring before the board? Okay, if not, meeting all the requirements for the agenda, I'm going to declare us adjourned. Thank you all.
Thank you.
Thanks, Dr. McGuire. Thanks, Dr.
Thanks.
Thank
Bye-bye.
you. Thank you.
Thank you. See ya.
Okay.
Over 13 minutes.
Yay. The gift of time.
I attribute that to a well-run organization.